Hi, I'm Makara Kerr. I'm one of the pediatric anesthesiologists at Massachusetts Eye and Ear Infirmary. And today I want to talk to you about operating room setup for pediatric airway cases. So as an anesthesiologist working with pediatric ear, nose, and throat surgeons, you'll sometimes come across a patient that needs an evaluation of his or her airway under anesthesia. It's important to understand what to expect and what to be concerned about in pediatric patients when the airway pathology is unknown. Imagine a 3-year-old child presents with a history of recurrent croup and stridor that worsens with upper respiratory infection. The parents state the child was born at 28 weeks and was intubated at birth for respiratory distress. He is scheduled for an elective laryngoscopy and bronchoscopy. Direct laryngoscopy and tracheobronchoscopy under general anesthesia is the gold standard for diagnosis of any laryngotracheal abnormality. I'm going to very briefly review the preoperative evaluation of a child with airway pathology. However, my primary focus will be on how to prepare the operating room as an anesthesiologist taking care of this type of patient. As with any pediatric patient, it's important to interview the patient's parents and review the patient's medical history and record. A full review of systems should be performed and include a birth history and any need for resuscitation, NICU stay, or need for positive pressure ventilation and intubation. In a patient with stridor and airway concerns, the timing, onset, and duration of stridor, any feeding abnormalities, failure to thrive, and possible foreign body aspiration are important to ask about. It's also important to examine the patient and carefully characterize the stridor. In this patient with stridor and recurrent croup and a history of prematurity with intubation, subglottic stenosis is of concern. In terms of other anesthetic concerns, the airway will be shared between the surgeon and anesthetist during the procedure. When airway pathology is unknown, maintenance of spontaneous ventilation is preferred. Preparation is always of utmost importance. The operating room setup should include airway equipment, medications, suction, intravenous and intraosseous access devices, infusion pumps, if these will be used. The availability of pediatric advanced life support cards, known as PALS, P-A-L-S, or other materials should be immediately available in the event that life support and resuscitation is necessary. We place these PALS materials on each anesthesia machine in every operating room and on all code carts. Airway equipment setup should include direct laryngoscopy blades, laryngoscopes, masks, oral airways, endotracheal tubes, LMAs, glide scopes and fiber optic bronchoscopes, as well as a cricothyrotomy set and tracheostomy set in the operating room. Medications include emergency medications and induction and maintenance medications. Emergency medications such as succinylcholine to treat laryngospasm, atropine to be given with succinylcholine, and treat bradycardia and epinephrine should be present. These drugs should be drawn up with correct dilutions and doses for the specific patient. Other medications include inhaled anesthetics, propofol infusions, remifentanil infusions if available, or fentanyl or morphine for small judicious intravenous boluses. It is important to maintain spontaneous ventilation, so infusions of medications are ideal in this setting where the airway is natural and shared with the surgeon. Infusion pumps should be set up prior to entering the operating room to start the case. Dexamethasone 0.5 milligrams to 1 milligram per kilogram IV up to 12 milligrams should be given if the surgeon prefers to decrease post-procedural airway edema. If the patient does not have IV access prior to entering the operating room, preparation for access in the operating room should be made. Intravenous access supplies should be prepared in the event that this access cannot be obtained. An intraosseous set should also be in the operating room. The surgeon should have a rigid bronchoscope with an ET tube loaded and a cricothyrotomy kit prepared. In addition, lidocaine in a syringe should be available to directly spray the vocal cords. This decreases the risk of laryngospasm. Just prior to entering the operating room, it's extremely important that the whole team, including the anesthesia team, the scrub techs, the nurses, and surgeons, huddle to discuss the case. The huddle should include the procedure expected to be performed, the possible expected pathology of the patient, any special concerns for the patient, any and all equipment supplies needed, and the expected order of events. All members of the team should introduce themselves if they are not familiar with each other. Everyone involved in the procedure should be involved in the huddle, and all plans and backup plans should be understood by the full team. Only then should the patient be brought to the operating room for induction of anesthesia. In many cases, the surgeon needs to be present for induction, and this should also be discussed at the huddle.